Hi, today's lecture is going to be on the endocrine system. Objectives are going to be looking at hormones, steroid versus amino, the structure and location of the endocrine glands, the name of the hormones in the endocrine system, and the function of them, and roots, prefixes, and suffixes that go along with the endocrine system, along with some disorders that are commonly seen. Hormones are very potent, so you only need very minute amounts for them to have an effect. They affect everything, including growth, metabolism, behaviors, and reproduction. We touched on some hormones from the endocrine system briefly in the reproductive system, if you remember, luteinizing hormone and follicle stimulating hormone. And they can be made up of lipids, those are the steroids, or amino acids. So a quick overview of the anatomy of the endocrine system. Some of these we've already seen, so hopefully we'll be able to tie this all together and see how the different systems start to interact with one another. Yes, we do study them separately, but they do interface and have profound effects on one another. So in the brain, you have the pineal gland, the hypothalamus, below that, and we'll move down the body, the pituitary or hypophysis. Into the neck, we have the thyroid gland, this butterfly-shaped structure in the neck, and the parathyroid are some little red dots here. It's closely associated with the thyroid gland. And the adrenal gland, which we've seen before, sitting right on top of the kidneys. The pancreatic islets in the pancreas, and that is what we'll see when we're looking at diabetes primarily. And then in women, we have ovaries, which we've taken a look at, and in men, the testes. Let's start at the top with the pituitary, also called the hypophysis. It is directly beneath the brain, deep inside. There are two lobes, the anterior pituitary with 6 hormones, and the posterior pituitary, which has 2 hormones. And these hormones are all involved in feedback loops, both with each other and the systems they primarily have their effects on. Moving down to the thyroid and parathyroid. The thyroid has 2 lobes. Like I said, it was a butterfly-shaped structure. You can think of the lobes as the wings of the butterfly. They are located in conjunction to the larynx and trachea. And they primarily affect the rate of metabolism. The parathyroid glands, depending on the person, can have 4 to 6 of those. Not really sure why there are different numbers in different people. It's just the way it works out. And they are on the backside or posterior surface of the thyroid. And the parathyroid regulates the amount of calcium that is circulating versus the amount of calcium that is in the skeletal system. So a closer look at the structure of the thyroid and parathyroid. Here we have the right and left lobes of the thyroid hormone being connected by the isthmus of the thyroid gland, sitting directly below the larynx, and the hyoid bone, which you can feel with your fingers in your neck before it goes into the cartilaginous larynx. And then if we look at the backside, if we turn this around and look at the back, we'll be able to see the parathyroid glands, the ones that are involved in calcium level regulation, right there. So if you actually look back through someone's neck, that is where the parathyroid glands will be located, on the posterior side of the thyroid gland. The adrenal glands are on top of the kidneys. There is the outer cortex. Once again, here we see that word, the outer being the cortex of the adrenal gland. The cortex is responsible for the production and release of cortisol, aldosterone, and some of the sex hormones as well will come from the adrenal glands. And then the inner, or the medulla, there is that word again, if you remember that from the nervous system amongst other systems. That is where your epinephrine is released for your fight response and the fight or fight response to stimuli. A closer look at the adrenal glands. Sitting right here on top of the kidneys, little cap on the kidneys on the left and right. And as we mentioned earlier, we have the outer adrenal cortex and the inner adrenal medulla, and all surrounded by a protective capsule as well. Right there. In the pancreas, you have islets of Langerhans, or the islets of the pancreas, that produce insulin in response to increased levels of glucose. And when sugar levels drop, more insulin is produced, so more circulating glucose can be in the bloodstream. And also in the pancreas, you also create and release glucagon, which decreases the amount of glucose that the cells use, and the sugar levels in the blood increase in response to glucagon. So, should be able to kind of figure out if someone has extremely low blood sugar, glucagon is going to be what they need to bring those blood sugar levels back up. The pineal gland, that was up in the brain area as well. This is where melatonin is produced, and it is primarily involved with daily rhythms. And I've used melatonin in pill form to try and regulate, and with varying degrees of success, jet lag. You start taking melatonin 1 to 3 milligrams at the time you want to be sleepy in the time zone you're going to a few days before then, with the thinking being that you're resetting your clock to the rhythm of the area code that you are going to be into. And then we're also talking about light, particularly in the Northwest. A lot of that, the seasonal affective disorder, or SAD, that is related to the amount of light that you received. We're looking at the pineal gland and the melatonin connection to the amount of light that you're exposed to. The thymus gland in the chest makes thymosin. And you have the gonads, which you've taken a look at in the previous lectures for the sex hormones. There's a group of hormones called prostaglandins. They are made in a lot of different places. They're involved in things as varied as causing the contraction of the uterus in childbirth, involved in the inflammatory response. So when you see things like NSAIDs, non-steroidal anti-inflammatory drugs, examples being aspirin, ibuprofen, naproxen, they are interfering with prostaglandins' effect on the body and other vasomotor activities. Let's take a quick look at these roots and see if anything stands out. This is something we haven't seen yet. We did a pretty good job of taking a look at those. Parathyroids. Here are some key terms that we'll want to keep track of. And these should all be familiar to you after listening to the lecture. Oh, target tissue. That's one that we didn't see. So that is the tissue on which the hormone acts. For instance, the sex hormones act on developing secondary sexual characteristics, for instance, or an LH or FSH surge will cause the release of eggs and the development of the uterus. That would make the lining of the uterus the target tissue in that case. Okay, so when a person ages, you have decreased hormone production and secretion, and they are metabolized differently. Obviously, because metabolism does change, slow down primarily as a person gets older. Type 2 diabetes often develops as the pancreas ages specifically, and that is in response to less insulin being produced. And also thyroid tends to decrease. This will lead to fatigue, dry skin, and forgetfulness. Some more general clinical aspects. You can have too much or hyper secretion of hormones, not enough or hypo secretion of hormones. They can be secreted at the wrong time and throw homeostasis out of whack. And the target tissue might not have the receptors needed to respond to the hormones. They can be caused by the actual production of the hormone and in the hypothalamus, which we'll take a closer look at, and pituitary, not enough of the hormone stimulators. Again, we're talking about those feedback loops. As things increase, they will cause a decrease in release of other things and vice versa. And sometimes that system breaks down and you don't have the proper response to stimuli that you should. So let's look specifically at the pituitary gland. So a pituitary adenoma or cancer causes too much growth hormone. If you get it in children, a person develops gigantism. That's when you see people who grow to be over 7 feet tall because they've had an adenoma in their pituitary gland from a very young age. If you develop an adenoma after you've already reached adulthood, you end up with a condition called acromegaly, and that causes an overgrowth of bone. So you'll see foreheads that stick out, jaws that are too big, those types of things, and not necessarily large, but it's an overgrowth of tissue. And drugs and surgery can reduce the adenoma. So you have panhypopituitarism is the hypo, not enough pituitary hormones being released. It can happen again from a tumor or the blood supply, and it affects the whole body if the pituitary gland is not secreting enough of its hormone. If you don't have enough antidiuretic hormone, this is what's called diabetes insipidus. So water cannot be reserved. You don't have enough antidiuretic hormone. Again, you have to keep that. Antidiuresis, so if you have enough, you're holding on to water. If you don't have enough of the thing that prevents you from withholding water, you can't conserve the water. You end up with excess urination and thirst, obviously. Polyuria and polydipsia. Here is another hypo condition, hypothyroidism in this case. So there's not enough thyroid hormone. If it is in a child, there can be problems with later mentition, ability to think, and physical retardation as well. If you develop hypothyroidism as an adult, can think as thyroid gland as the gas pedal on the body. So if you take your foot off the gas, slow the metabolism, you'll end up with weight gain, tiredness or lethargy, dry skin again, hair will fall out, and there will be a retention of fluid in the face causing swelling. Hyper, or when there's too much thyroid gland, you end up with a condition called Graves' disease. In this case, you are putting the accelerator pedal down to the floor and you'll end up with weight loss. Be irritable, tremors, increased heart rate or tachycardia, bulging eyeballs called exophthalmos. We'll see a picture of someone with exophthalmos soon here. You can treat this with anti-thyroid drugs, just reduce the amount of tissue that's making the thyroid gland, and you can take out, surgically remove part of the thyroid gland to remedy the situation as well. And there may be a goiter. Goiter is another name for an enlarged thyroid in the neck. So here is a person with Graves' disease. You can see the pronounced exophthalmos in this case. She is not purposely opening her eyes or anything like that. But there are fatty pads on the back of the eye that overgrow in hyperthyroidism. So the parathyroid glands, again, on the back of the thyroid gland, there are 4 to 6 of those. If you have hyperparathyroidism, you have too much thyroid gland and you have high levels of calcium. And you can end up with kidney stones because that excess calcium will accumulate in the kidneys and crystallize and cause kidney stones. And the bones can get weak because they are taking that calcium from the skeletal system and put it into circulation. If it's underactive or hypoactive, hypoparathyroidism, you of course have the opposite with decreased calcium. In that case, there will be a tingling a lot of times and numbness because the nerves aren't functioning properly, as well as tetany. If you remember when we were talking about the muscular system, tetany being a involuntary contraction of skeletal muscle. And calcium is heavily involved in the contraction of muscle. In Addison's disease, there is hypofunction of the adrenal, in this case the cortex. Remember the outside? You can have autoimmune or a person's own immune system destroying that tissue, and the main hormone that is affected is ACTH. You'll end up with not enough fluid being retained, low blood pressure, electrolytes that are going out with the water, and that follows with weakness, nausea, and a brown pigmentation. And I don't really know why you get brown pigmentation in Addison's. Haven't seen a good explanation for it, but it is something clinically that is oftentimes seen. And you can take cortisol to replace the lack of ACTH that is released in the hypoadrenal system. So if you have excess or hypoadrenal corticoidism, you end up with Cushing syndrome. You can get that if you're treating another disease with steroids, a person can develop secondary Cushing Syndrome, or there can actually be a tumor that grows in that area that causes too much of the hormones to be released from the adrenal gland, in the cortex of the adrenal glands, and you get a moon-shaped face. Obesity. Hirsutism is another name for too much hair and fluid can be retained. And this, here we see a woman with Cushing syndrome and the associated moon face, because your face is very round. What's called a buffalo hump right here overlying the traps. The facial hair, of course, which is somewhat unusual in a woman, and the receding hairline to a certain extent as well. Let's move on to diabetes mellitus, and we're looking at a malfunction in the pancreas. Diabetes mellitus is the most common endocrine disorder, and this is involved in the regulation of glucose levels. If you have too much glucose, that is hyperglycemia. And glycosuria, remember from the urinary system, and glycose being sugar, is the body's trying to get rid of the glucose through the kidneys, and you'll end up with polyuria, too much urine being produced and released. So type 1 diabetes mellitus, is when the pancreatic islets don't make insulin. So you can diagnose that by doing a glucose stress test, basically drinking a glucose solution and seeing how the body responds to processing that glucose. And the glucose tolerance test. And to treat it, you can monitor blood sugar levels and need insulin to replace the insulin that is not being produced by the pancreas, and stay away from sugars primarily in the diet. More complex carbohydrates and those types of things. Type 2 diabetes is not necessarily the inability to create insulin, but is the target tissue's inability to respond to insulin. So type 1 is a lack of insulin. Type 2 is the resistance to normal levels of circulating insulin. And again, you have almost the same means to diagnose it, and obesity is often involved because fat tissue does not process glucose as well, and it kind of becomes a vicious cycle. A person gets heavier, predisposes them to type 2 diabetes. They develop type 2 diabetes, which causes people to retain more body fat, and becomes a vicious cycle. So controlling the amount of fat a person carries is very important in treating type 2 diabetes. So exercise and weight loss is definitely part of the treatment plan, and you can increase insulin production, and you can take other drugs that will help target tissues respond to insulin. And later on, after a while, insulin can be given, but generally when people first are diagnosed with type 2, they don't need insulin to treat it. That develops over time as the case gets more severe. Pregnant or gravid women can end up with gestational diabetes mellitus, and that develops specifically during pregnancy and will usually need to be treated by insulin injections if the blood sugars run too high. And metabolic syndrome, or syndrome X, is a very big problem that is developing, not just in the United States, but worldwide, is hyperglycemia, because the tissues become resistant to insulin. And this seems to be very much involved with high body fat levels due to diet and lack of exercise in modern societies. It's predisposing people. You can think of this, it's also called pre-diabetes. You might necessarily have type 2 diabetes, but you're on the road there once you start developing the symptoms of metabolic syndrome. So let's take a look at MG. So she has type 1 diabetes. Remember, that is the inability to make enough insulin or any insulin at all. Let's look at 3 symptoms that she exhibited that initiated the visit to the doctor for her diagnosis. Actually, there are 4. So she was very tired. Obviously, if the glucose isn't able to be processed, a person gets very tired. Even if there's enough food technically being taken in, if it's not making it to the tissues, the person's going to be tired. So that's going to make you very hungry. You might be eating, but your body is not being satisfied by the food you do eat, and very thirsty. As we talked about before, the body is trying desperately to get rid of that excess glucose that's not being used, and the water is following the glucose out in the kidneys, and that is causing thirst. A person cannot heal well when they have out of control type 1 diabetes. And of course, wetting her bed or polyuria developed as well, as her kidneys were getting rid of too much water. Okay, let's get again at some terms that we have studied. Let's make sure we've seen them all. Acromegaly is the overgrowth of bone and soft tissue in an adult when they have too much growth hormone. And we saw Addison's disease. And we looked at the patient with Cushing Syndrome. So diabetes insipidus, that's when not enough antidiuretic hormone from the posterior pituitary. That wasn't mentioned during the lecture, but ADH is made in one of the pituitary glands, in this case the posterior gland. So you have excess thirst and lots of dilute urine. Diabetes mellitus we talked about, type 1, which is generally one that's developed when a person is young, and type 2 in obese adults. And exophthalmos in Graves' disease, gigantum in children that have too much growth hormone. Glycated hemoglobin, HbA1c. So that is glucose to hemoglobin in the blood, and it is a test that is the average blood over 2 to 3 months, actual average blood glucose over 2 to 3 months. So you can see how someone's glucose control is averaging over that period of time. You can also call it the A1C test. So you might have a patient who says, oh, I keep great logs of my diabetes. I'm testing 3 times a day, and they have a log book, and it's all, 100, 90, looks great. And then you take an A1C test, and it is well in excess of 10, which indicates that the person does not have good control of their blood glucose levels at all. So you know that they're probably fibbing a little bit to try and keep their doctor happy, get them off their back, and then it's a chance to intervene and see if there is some hole in their diabetes treatment that you could help close. Graves' disease, hyper and hypoglycemia, and our last slide here. You can have insulin shock if someone takes too much insulin. and all of the glucose is driven out of the blood system, and primarily the blood starts to run out of glucose to run, and you can end up with brain damage if it's too severe for too long. And so in diabetes mellitus, you can end up with ketoacidosis, too many ketones in the blood. And the other ones we also went through. Okay, thank you very much. And if you have any questions, feel free to reach out to me if any of this was not clear. Thank you very much.